Great. This meeting is being recorded. It is a public meeting. The recording will be posted on the committee's webpage shortly after the conclusion of the meeting. And for everybody's reference, your agenda for today's meeting can be found under the first tab in our materials. I will, in lieu of Judy, call the meeting to order. Thanks everybody for joining today on May 25th. And I will start with an overview of the agenda. So one more, actually. Two. Yeah. There we go. Perfect. So we'll start with roll call, and then after I call roll, we're going to vote to approve the meeting summary for April. And then we get to hear from Michael Baylett, president of Baylett Health, and he's going to talk with us about how to define non-claims-based primary care spending. At the conclusion of Michael's presentation, we're going to hear from our colleagues from the Center for Evidence-Based Policy, who will do a couple of short polls to gather feedback from committee members. And then at the end of the polls, we're going to hear from Karen Hampton, who is the lead for Oregon's all-payer, all-claims database for the Oregon Health Authority. Karen is going to speak with us today about Oregon's process to measure non-claims-based primary care payments. And at the end of her presentation, much like after Michael's, our CEVP colleagues will conduct another poll from committee members to gather feedback. And then Judy will proceed where we left off at our last meeting and lead the committee through discussion and voting on the remaining code level sets. And then sharply at 3:45, we will open the floor for public comment. Thank you all for attending, and I am now going to begin roll call based on first name in the order you see on the screen. Crystal. Okay. Sharon Brown. Is anybody having difficulties with their microphone? I just want to make sure. Should be able. Yeah. Okay. If you're having difficulty, go ahead and use the chat for now, or if you can email the board email, that would be better to let me know that you're here. Tony. Michelle. I saw Nancy. Tracy. David. I saw DC.
Yeah, here.
Yep. Okay, great. We get a voice. That's great. Sharon Eloranta. And I know Greg said he couldn't be here. Chandra.
I'm here.
Thank you. Meg, I saw you.
Great. Thanks.
Yep. Cheryl, I saw you. Cheryl Morelli and Lan, I know you were having technical difficulties, but I saw you. Kevin. Eileen. Katina, I know you're here. Mandy, I saw you. Jonathan, I saw you. Sarah. Don't know if I saw you. Linda, I know you're here. Sean. Stacy, I know I saw you.
Good afternoon. I'm here.
Great, thank you. Ginny. And Maddie, I saw you.
I am here, yes.
Okay, so for those of you where I did not hear anything, if you are here and I called your name and I can't see you right now because I'm toggling between, if you could please either, well, just email the board, that the board inbox would be helpful. All right, we're going to tab to the meeting summary. Is there any discussion of the meeting summary or proposed changes? Would someone like to make a motion to accept the summary?
I'll make a motion.
Moved.
Beautiful.
Second.
Great. Any discussion? All in favor say aye.
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 Beautiful. Any opposed? Okay. Approved by consensus, and now we'll move it along, and I would like to introduce Michael Baylett of Baylett Health. And he is going to give us a presentation on non-claims-based primary care spending. So welcome, Michael. And do you have control of the screen now?
I don't know. I don't think I do.
Okay. Serena, can you make it so that Michael can be a co-host? I thought he already was, but
I need you to unscreen share whoever is, and then Michael can take over. Michael is a co-host.
there we go. Great. So you should be able to share now, Michael.
Great. Thank you so much. All right. Well, good afternoon, everyone. It's a pleasure and an honor to be with you. Okay. Can you see my screen?
Yes.
Great. All right.
It is on the slide move. There you go.
Great. Okay. So I am going to share with you the product of some work that we did for the Millbank Memorial Fund a couple of years ago that was focused on measuring non-claims-based primary care spending. And I'm going to share with you the methodology that we developed through that work. And then we'll be happy to entertain any questions that you might have. So the Millbank Memorial Fund, as many of you might be aware, has been a big booster of primary care, and they believe that standardized measurement of primary care spending will bring attention to the need to financially support primary care. And we had performed some work way back in 2017. Mark Friedberg, my colleague Martui, and I authored a publication looking at methodologies for measuring claims-based primary care spending. 3 years later, they had Rand do a concept piece in 2020 on measuring non-claims-based payments, and then they asked us to do a follow-on piece. And so this is really the result of that work, which was published in 2021. Measuring primary care spending using claims is fairly straightforward, but it is not so straightforward doing it for non-claims-based spending, and those states that measure it at all do so with a lot of variation. So that's why we were focused on non-claims-based payments in this work. And so here's a little math formula to calculate primary care spending as a percentage of total healthcare expenditures. We want to have both the numerator and denominator claims-based payments. We are focusing on the non-claims-based payments. So we convened an advisory group at the request of Millbank that had payers, providers, and state officials in 2020 to advise us on this. They discussed a number of policy and design issues in the course of 4 meetings, again, building from the prior research work that Rand had done. We also, after developing the recommendations, took them to insurers in Colorado and Rhode Island and said, hey, do you think that this is feasible and this is a good idea? So that was some proverbial tire kicking that we did after we developed the methodology. So this is the resulting publication, came out just about 2 years ago, and you can access it on the Millbank website if you have interest. So our methodology has a series of recommendations. The first is that states should adopt a standard categorical framework and collect non-claims-based payments by the subcategories within the framework. And I'll review what we recommended. 2, states should apply a default percentage to each subcategory to determine the primary care portion of non-claimants. The meaning of this is not self-evident, so be patient, and I will explain this a little bit later because this is the most complicated part of measuring non-claims-based primary care spending. We recommended that in the denominator, states include all non-claims-based spending except any non-claims-based spending related to long-term care and dental services. We recommended that data collection reporting be at 4 levels. This is consistent with what you're doing with your healthcare cost growth benchmark, state, market, insurer, by market, and large provider entity levels. We recommended working with a technical advisory group to figure out how to implement the approach. We found that to be can be a highly collaborative and value-added strategy. And then we recommended states be clear on the population for which data will be collected. So I'm going to talk about each of these just to clarify what our recommendations were. So first one, a standard categorical framework. We recommended these 6 categories for collecting non-claims-based payments. You can see within each category there are subcategories, and we thought there would be value in collecting the spending data by subcategory to give insight. So why ask for the subcategory? So first, it gives insight into the composition of primary care payments within the state, which might inform policymaking. 2, it could be used to help evaluate the impact of value-based payment models. And 3, it helps to validate the data provided by a payer. So if a payer reported nothing in a subcategory and you knew it was highly unlikely that there was nothing in a subcategory, then that might be grounds for going back to the payer and saying, are you sure that this is accurate? So those are the 3 different reasons that we thought that made sense. When we developed these categories, we thought about would they be feasible for payers to report, and would there be value in having the information? And so that's when what went through our mind. The framework focuses on the purpose of the payment rather than the modality of the payment. Okay, so that's what those categories for. Last thing I'll note, 5, recovery, that's actually a negative payment. Okay, so the most complicated part of figuring out how to collect non-claims-based payment that's specific to primary care was figuring out what to do when you have non-claims-based payments that go to health systems, multi-specialty medical groups, and any other type of provider organization that includes more than just primary care clinicians. Because in those cases, there might be a payment that is being made for more than primary care. So imagine, for example, that there might be a total cost of care shared savings arrangement with a multi-specialty medical group. And there's a shared savings payment made after the end of a performance year. It would on the surface not be clear what percentage of that shared savings payment went actually to primary care clinicians who were part of the group and what went to the specialty physicians. So this was something that we had to struggle with. This is not a problem with primary care only entities. And it's not an issue with organizations that don't have primary care clinicians. But again, for these mixed provider entities, it is more complicated. So what we recommended was that when the spending data are collected, they be categorized. And so you can see here, table 1 is payments to primary care only organizations. Well, all the non-claims-based payments, they're going to be primary care 100%. And table 3, payments to organizations that do not include primary care clinicians, 0% is primary care. But this number 2, payments to health systems, multi-specialty provider organizations that include primary care, here we have to determine what percentage of the spend goes to primary care. So you can see in this reporting template that there are some percentages built in here. So if it's primary care capitation, we're in this simple model, we're assuming it's 100%. If it's a global budget payment, we're assuming it's 6%. Could you have other subcategories? For example, professional capitation, that's primary care, but other professional services, yes. And you would have to have an estimate of the percentage that would go directly to primary care. And so we spent some time thinking about these percentages, and our feeling was it made sense to develop default values. We did envision that it might be possible and maybe desirable for some provider organizations to share what's the actual rather than use a default, but we were very cautious about having to go to provider organizations and ask them to tell us their organization specific percentage. So we recommended having default values that were informed by conversations with provider organizations within the state, but not having different percentages for every provider organization. All right. This is the hardest part of measuring non-claims based primary care spending. Right, filling in that box right there. Okay, our third recommendation was that when defining the denominator for measuring primary care non-claims based spending, that pharmacy rebates be included, but long-term care and dental services for non-claims based services, but frankly for claims based services too, be excluded. And the reason being to allow for a comparable measurement of primary care spend percentages across Medicaid, Medicare, and commercial populations. And in fact, in work that we do in states that currently are measuring their primary care spend, that tends to be the standard approach. We recommended reporting at 4 levels. As I said earlier, I believe that this is the approach that the healthcare authority is using for measuring cost growth benchmark performance. We did spend some time talking about large provider entity and did that make sense? But we thought that it did because it would give first some insight into adoption of value-based contracting at the provider entity level. And we know that that provider organizations have some degree of influence over distribution of payments among their providers. The next recommendation was to convene a technical advisory group or groups to support implementation. So it would be possible to talk through that template that we talked about before to make sure that that non-claims based spending included any state specific programs, to talk through operational issues for collecting and validating the data. If there are other primary care spend efforts within the state, like the cost growth benchmark that I talked about before, which is collecting primary care spend, I believe, to make sure that the methodologies are aligned. And then to make sure that there's consistency when benchmarking with other states. There are some issues on the population for which data will be collected. This is not specific to non-claims based payments, to be honest. This is something that you all probably have been considering as part of your broader scope. But to find the location of the patient, resident, and of the provider is important. And we've shared some advantages and disadvantages that I'm not going to talk through right now, but we called out some that states could consider. And also the status of the insurance contract for to find the population. Again, this is not specific just to non-claims based payments. This is relevant for claims based as well. Okay, so I ran through that. Again, I think the most critical issue is developing the categories for non-claims based spending and then figuring out what to do for non-claims based payments that are going to organizations that include more than primary care clinicians. And I think we offered both in terms of the categories and the distribution algorithm potential framework that you can consider.
Very much, Michael. Nancy, looks like you have a question.
Hi, thanks very much for that interesting framework. So I'm a primary care doctor and I'm very motivated to see more spend in primary care, the right kind of primary care. And I'm also very motivated to see that payment drives the way I understand, not that I think it should be, that I understand that the way we get paid drives sort of to some extent what we do. And so in this modality, we're counting what we're spending. But what if there are things we ought to be spending that we're not spending now? Like, for example, part of our definition includes a team-based approach, and yet there's no way to bill for the time we spend as a team together, talking about, and you could talk about that as perhaps that would be capitated, but it's not capitated now. So I guess my question is there a way to build in spend we might do that we're not doing in order to incentivize us to do it, if that makes sense?
Yeah, Nancy, I would say that's more of a payment model strategy. What I described is really just a framework for measuring spending. I spent 2 hours yesterday afternoon helping facilitate a similar group to this one in Oregon, where they've been working for a long time on a consensus multi-payer value-based payment model. I think that's where your question gets resolved, is how do you build a payment rate? And in that work group in Oregon, we've actually talked about this. We've said, look, if we're building the payment rate, but historical payments don't include coverage of things that we want to include, how do we make modifications? Because the historical spend that we might want to include to develop our rate is missing something that we want added.
Exactly. Yeah. So I'd be curious how you add that to your model, but maybe we're not there yet.
Yeah, and what I just presented is really just the back end, how do you track the spending and recognize that there are portions of primary care spending that are not claims. And if you want to capture that, what's a standardized way for doing so?
Other questions from folks? Serena, I don't know if you can see folks raising their hands easier than I can. I feel like I'm only seeing a limited.
There are no hands raised. I can see.
Okay, okay.
Hey, Michael, it's Cheryl. Would you, I can't say I've totally thought through this, but any difference between if you were looking at pediatric only versus health system that takes care of the adult only or the entire age range?
I don't think so, Cheryl. I don't.
Because
I don't think there are any. I don't think there are any pediatric versus adult differences in capturing spending in those categories. Are you thinking there'd be different categories of non-claims based spending for pediatrics?
yeah, I don't know. I don't know. I mean, almost in every other, that we are always different, almost always, when we say, well, what about peds only? We do so much more preventative than, because kids are generally healthy. And so this always looks different for a bit different for us when we look at the spend, what we're claims-based spend. It is a little different. And I'll completely agree with Nancy on what we would like to be spending on would be, I think, a little different for us too. But I haven't thought it through completely. I just wondered if you knew, because you do think about this all the time. I just wondered if anything has come up.
Yeah, not for what I presented today. I mean, yes, there are all sorts of differences in primary care for children and adults. And as I probably disclosed to you before, I am the son of a pediatrician who is turning 100 this summer. But I don't think so.
And then can you put the probably one of your first slides up that had the different payment types and because now I'm feeling it's a little hard to answer the question without having the slides up.
Okay, so I thought I brought them up. Do you see them?
Yeah, yes, it's on your yes.
All right.
Yeah. Ooh.
I went too far. All right. There you go.
Yeah, there. Thank
Yeah.
you.
Yeah, I don't, is there anything here that would, it's like, is there a category missing here that would be specific to kids that's not, that should be here?
No, I don't think so. I mean, we, care management, right, payment per member per month care management payments are not uncommon for peds and where do you? And again, none of this is not specific to peds, and the quality only like gap payments, you would,
That's number 2.
that's not, goes in number 2.
Yeah.
Well, does that go in number 2? Just the,
Yeah,
oh,
retrospect.
P for P, I see it. Okay, yeah, thank you.
Now, it might be interesting to see how the percentage of non-claims based payments going to pediatric practices differs from non-pediatric practices, or how the distribution by category or subcategory varies for pediatric practices. But I think these categories and subcategories all work for internal medicine, family practice, and pediatrics.
And then just, Michael, you, number 5, recovery, I mean, that is the, I have to pay back something, right? Thank you.
Sorry, Cheryl, didn't mean to go over you. Maddie, you have a question?
Yeah, sorry, and I may have missed it, but what is the payments for primary care provider salaries? I'm not sure I understand how that fits in.
Yeah, so this is to account for sort of a staff model employed position where there are no claims. So I think we were contemplating a Kaiser-like arrangement. I shouldn't say Kaiser because Kaiser's capitated, but where there were no claims paid. So that's what it was.
Other questions?
Sorry, are there systems where there's direct payments, direct salaries for providers in uncapitated models?
So we developed the framework, but we left it to be implemented by states, but we didn't implement it with states. So I can't tell you. But we wanted to allow for the possibility that if that existed, that we had a category calculation.
Nice owl there.
A snowy owl. My wife took that photograph this winter.
Beautiful. And so were you saying your dad was turning 100?
Yeah.
Well, congrats to him and to you. So if there are no more questions, Shane, do you want to share your screen to take the polls?
Yeah, sure do. Right. So ultimately, we have the task of taking all of the different learnings that we gather from speakers and the different committee meetings, and we'll have to boil them up into recommendations at some point. So what we want to do today is just give you an opportunity to poll your thoughts and reactions to what was presented, and to the extent that there was something that stuck out as a highlight for potential action, we'll be asking about that. So after each of these presentations, we essentially have 2 questions for you. Let's see here. I am clearly not a great multitasker, so 1 second. So can you see the presentation?
Yeah. Yep.
Okay, great. So we've done this before. We're using the same platform, but for the first question, if we can have you go to pollev.com /CEBP OHSU 925. If someone could drop that in chat, that'd be great, but you can also see it at the top of the screen here. And this is similar to the last time where we met, where you can type in your reactions, your responses to this question. And if something resonates with you that someone else puts down, feel free to upvote it. If it deeply offends you, feel free to downvote it as well. But really just the question here, what were the most important takeaways from your perspective from what Michael presented? We'll give you a few minutes to think about that, to go to Poll Everywhere and to input your options and provide feedback on your peers.
And thanks, Jonathan, for putting that in the chat so swiftly. Oh, I don't think, sorry. Yeah, we want to give that back to Shane. Sorry, Shane, can you pull that back up?
Yeah, no worries. One sec here.
Are you getting some feedback coming in? Can't see any response, but
Not yet, but we might give people a second to think about it. There we go. Well, that's sure a true statement. So this is complicated and it will never be perfect. And so even thinking back to the question that Charlotte asked about pediatrics being slightly different, and then in Michael's presentation, how there are some areas where you have assumptions about what percent is allocated to primary care and how maybe there's some differences, but you know, I think you do have to figure out, or collectively we're charged with figuring out what's the level of granularity that gets you a reasonable result, but is also aligned with the availability of data and is relatively parsimonious in terms of process, so that you're not significantly increasing administrative burden or introducing the opportunity for error. Some additional comments, so that there needs to be a system for capturing the percent of global payments and shared savings that go to primary care when the payment as a whole goes to a larger multi-specialty organization. And that's definitely a key takeaway. Variation makes a streamlined approach difficult. Scroll down a little here. I like the level of detail and I'm looking forward to reviewing the slides further. Great. Okay, we will wrap this one up and we'll give you 30 more seconds if there's anything else that comes to mind here. Swap these over to make it a little bit bigger here. New comment, the method makes sense to me. Agree it will never be perfect. I would like to see an estimate of the precision of the proposed method, meaning what is the range of confidence? We still don't know if Mr. Baylett's parent is still accepting new patients.
Believe it or not, he practiced until 89. He retired and he said, I'm retiring now because I want to go out at the top of my game.
I love that so much. That's great. Looks like we have another new comment here. So current payment measures and models are limited by what we do now rather than the potential for what we might do. I think that's an important comment too. So going back to the earlier conversation, we're going to have, you can think of it as there's really two bodies of work in front of us. So one is about how do you measure to the best of your ability primary care spend and other expenditures so that you can see what proportion of primary care spend you're at. And of course, based off of the statute, we're working towards 12%. The other body of work is around what we talked about last time, which is the payment policies and other ways to help increase primary care spend which can be diverse. So the direct payment was pretty popular, not surprisingly, but also looking at things such as promoting healthy utilization of primary care patient behavior, like getting people engaged in their own care. That'll increase utilization, which contributes towards that 12% as well. So there really are two bodies of work here. How do you measure, and then what are the policies to drive that? So we'll be spending a lot of time on that the rest of the year that ultimately culminates in recommendations. Okay, let me do a quick sweep here to see if I missed any. Oops. Sorry about that. Okay, great. Well, thank you very much. We are going to go to the next poll here. And this is where it starts to challenge you in terms of thinking about, okay, great. Well, we see what some of the key takeaways are. Is there anything that immediately comes to mind that something that jumps out as a potential policy or strategy that we should be adopting to address the key takeaways? And don't feel a ton of pressure on this one. This is where we're going to take time in future meetings to really walk through, like, what are some potential options to address these different strategies that Michael and Karen talk about today. But if anything comes to mind, we do want to capture that. We can fold it into, we can use it as a jumping off point in our next meeting. So we'll give you just a couple of minutes here to think about that and provide a response. First comment here. So I think our measurement strategy can adopt the categories listed for non-claims measurements. I'm not sure what would qualify salary, maybe the VA, but okay with keeping in case pure salary not associated with claims does exist. We need to measure things that matter to patients, e.g. my doctor knows me and I trust them to help me with issues important to my life or important in my life. Also, the comments, I agree with the categories. How close is Washington State to being able to measure now according to these? That is a good question, and I don't know the answer to that. I think part of the plan of attack is to take the learnings from the presentations today, connect with the folks that work on this on a day-to-day basis with the state, see how closely their capacity aligns with what some of the recommendations are, and then come back to you with, here's where we're at, here's where we think we want to go, here's the gap, and then work with you on recommendations to close those gaps. Another comment, ensure that payments for claims-based measurement backs out the current administrative component baked into claims payment rates if there is a non-claims-based component to primary care incentive payments. Yeah, this is all great fodder for our next conversation for things. So thanks for taking a moment to dive in on this. I will give you 30 more seconds, and if you want to add, feel free, and then we'll jump into our next presentation.
Thank you, Michael, so much for taking the time to come and speak with us today. We really appreciate getting us started.
My pleasure. I wish you all the best, and please feel free to follow up with any questions.
Thank you.
Thanks. And I just want to capture this last comment before we transition to the next presentation. I think this is a great recommendation. So see if there's any literature on how larger organizations divide global budgets or shared savings type payments, and if there are any patterns in what portion goes to primary care. So, all right, well, thank you very much for the engagement following the presentation. Like I said, we're trying to prepare ourselves for success in the future. And with that, I think we'll be transitioning to Karen.
Give us just a moment. presentation. Perfect. All right, so next we have Karen Hampton from the Oregon Health Authority. Great to have you join us today and share your experience. Karen, do you want to say any other words to introduce yourself before you get started?
Hi. I'm sorry, I have my chihuahua looking at my feet right now. Good afternoon. Thank you for inviting me here. I'm Karen Hampton, and I am with the Oregon All Payer, All Claims, or APAC program. I have been here 5 years, and before that, I was with the Center for Health Statistics, our state vital records office, for 17 years. Next slide, or do I have control?
You do not, so I will.
Okay, I'll just notice say next slide.
Yep.
So it's very difficult following someone like Michael in these kinds of presentations. And since we approach the subject at different levels and access points, our presentations will be very different at first glance. However, many of Michael's recommendations appear in my presentation as well, and I'll try to highlight those to clarify where we're not recommending different actions, even though we're using different terms, elevation. The essence is very similar, and the differences can be attributed to timing and to resources. As it relates to resources, I do want to mention that some of my slides may seem interrelated or even overlapping, and that's not accidental. I'm a baker, and except for the most heavily resourced, not only in money, but in cabinet space, I think bakers, cooks, mechanics, and many others would advise against almost any tool that's single purpose. A few are worth it, but the majority of tools need versatility to be valuable. As I talk about communication, compliance, resource planning, etc., you'll see that mindset several times in my presentation. Identifying who's required to report relates directly to Michael's fourth recommendation. Oregon created the payment arrangement file several years after our claims reporting. So I've approached the topic in comparison with our claims reporting. Who reports? Is it the same group or is it a different group? Certainly, if you have the opportunity, I recommend to influence the law, I recommend staying general whenever possible. We have a total of 3 statutes. One talks about who has to report to us. The second is about what is reported and a little bit of how on the standards. And then the third is compliance. On this slide, I have the who and what, the statutes paraphrased, but statements such as including but not limited to, or for the purpose of understanding healthcare costs in the state of Oregon, are wonderfully general and allow us to be flexible as needs arise. Next slide. We do not include all the groups Michael mentioned, although we certainly might if we were creating the program today. In the end, we opted to receive payment arrangement files from carriers, coordinated care organizations, and third-party administrators. Medicare Advantage, that we classify as carriers, and our employee benefit boards, contractors, are highlighted in our law and do have to report payment arrangement files for us. We left out our pharmacy benefit managers because at the time, and as far as I know currently, prescription costs are exclusively fee for service. Some carriers, however, do choose to report their pharmacy contracts if those amounts relate to a provider or clinic contract on total expenditures for patients. Michael's third recommendation on inclusions and exclusions. We do receive payment arrangement files from dental carriers, but we received those separately from the medical claims, in part not to dilute the primary care spending and to be able to keep our denominator and numerator cleanly in the category that could actually benefit from being assessed as primary care. Should we introduce any dental primary care in the future, then we may adjust that. We do not collect data from any long-term care organization, so that's already taken care of and fits his recommendation fine. And while we don't collect from large provider groups, our cost growth target does. Again, as Michael mentioned, a lot of the cost growth target programs are recognizing that large clinic groups can be cost drivers. But the cost care growth program started, I think, 3 years ago, and we started 12 years ago. So that we just didn't make the timing. Next slide. So then the next is who is reporting and, oh, and I'm sorry, this touches Michael's first, third, and sixth recommendations. So my recommendation is to let the data uses known and foreseen drive the data collection. One of the things Oregon has heard many times is that we're requiring data that does not exist as a data set. It must be created specifically to report to OHA. I absolutely want to acknowledge the cost to the reporters in collating, classifying, and reporting the data to us. However, there's a lot more freedom to gather information relevant to Oregon's interest in these summary contract files than in the more clearly secondary data sets of claims data. We're still having conversations with reporters on the internal reach for claims data. That is, if information is captured anywhere in the organization's activities, it must be reported. Those creating the claims files for APAT should not be limited to claims database or whatever format they have it in, if the required fields are somewhere else. The payment arrangement file, with the importance of primary care spending through capitation and other payment methodologies, pushes out of the payment database immediately and creates interaction among various parts of the organizations that are still developing for claims reporting. The primary difference for us in reporting is the selection or inclusion criteria. As Michael had shown on his slides, we use residents for the claims data, resident of the member, but we use situs of the contract for the payment arrangement file. The other difference is that we do act much more actively about what we're using the data for and what the review of it will be. Again, we recognize that this is a lot of work for reporters to provide this information to us, and we want to show that each component is actively used. So next slide. So straight from Michael's first recommendation, although a different format of it, Oregon adopted a standard categorical framework. In our case, the HCP LAN with 2 Oregon modifications that I'll go over later, and a standard layout with instructions. This is very important for data management and validation, which are both precursors to efficient data use. Next slide. We have a 16-page document for the payment arrangement file, including lookup tables and control table. We include the field type, the length, excuse me, whether it's required, always, or situational, a description or instructions specific to the field, and the error threshold. This is the requirements for our traditional file that you see in front of you, and it's significant for the communication it attempts to relay on the what, how, and quality level of the data. We do have an exemption, aka exception process, for the error threshold, but this establishes the minimum expectations. Next slide. We also accept an Excel version of the file. We have a 2-sheet Excel template that can be submitted to the vendor. Early on, so prior to our current vendor, we heard that the contracts unit would build the file in Excel, then they would hand it off to IT that would change it into a CSV file. It would go to our vendor, and then it would go back to the analyst who again put it in an Excel format. Although we no longer move to an Excel format for review, it is still valuable to have it, both because it is the format that is closest to the creation. So you have fewer of the transformation potential errors creep in. And it has value for the potential in data quality. So the Excel file is wider than the slide. So the first 2 rows are 1 row across in the payment arrangement file Excel template. The third one is the second worksheet that I'll talk about in a minute. So the way we do quality checks with the payment arrangement Excel template, the darker blue in the second row is a prorated amount that's generated by the Excel template as the information of the submitter is entered. And it's important for any kind of contract that is not exclusively within the reporting period. We receive these annually. We do January through December. So if, for example, a contract runs from July of 2020 to June of 2021, and has a payment amount of $1 million, this information will show that we're going to attribute $500,000 and half of the member months to the period that's currently being reported, because half the performance period is within that time. The individual reporter also has the option, of course, of reporting the contracts separately if the payments can actually be broken out in that way. Any row can have multiple, any contract can have multiple rows in it. And the same provider that we have in a off-year contract could appear concurrently in other contracts or subsequently with another contract that picks up in July of 2021 and moves forward. But the most important thing is that the data submitter can see what their data is going to look like to us before they ever submit it. The second way that we use this for data quality is the second worksheet. This builds that the data submitter does not complete any information on this worksheet. It is pulled from the first worksheet, and it uses the template information to give a snapshot of the summary information. For example, all the contracts in the commercial line of business that use payment model 3B will be grouped with the number of contracts shown as the number of unique provider, the number of member months, primary care payments, non-primary care payments, and as Michael has alluded to the difficulty of that, keep in mind that this is our definition of primary care, but their categorization as primary care, etc. And so then if you get to the end and you see the PMPM measures, this is going to give the reporter an idea if the data they're reporting presents the numbers they were expecting, or if they need to go back and check something. So it's just an excellent way for them to have a quality check before it ever leaves their door. Next slide. So I want to take a moment to talk about the complexity of creating the reports as it applies to data collection and use. So what do I mean by non-data? It's not in any way disparaging of the effort or the value of the data. I just want to acknowledge the importance of the instructions when having 50 separate external groups categorizing data for a summary report. Again, a baking comparison, Boston cream pie. According to at least some resources, this cake is called a pie because it was originally cooked in a pie tin. So the container was more important than the content. Now it's cooked in a cake pan, generally, at least. But even now, we still call it Boston cream pie. So the message would be, if you want to know the content and not the container, we need to make sure that we are calling something and describing it such that the reporters know what to give us. Say a contract section is identified with a dollar amount as primary care within a contract. That's great, but that's only the start of the process. Categorizing the data is difficult, as again, Michael said. I'm just trying to echo what he was saying because I completely agree with it. And APAC reporting for payment arrangement files requires two different categorizations. The first is primary care. APAC has a definition of primary care based on taxonomy of the provider or clinic and a procedure or diagnosis. How are these going to be accessible and knowable within a contract? The other is the payment methodology. Sometimes it's relatively clear, or appears to be on the face of it, as in a 4A monthly capitation per member, but only if there's a meaningful link to quality. Otherwise, it could be a 4N. So how is the quality demonstrated in the contract so that the reporter knows which category to place it in? Even after several years in new contracts, I haven't heard an insurer say that they're now writing their contracts based on land categories. So if you're collecting data on contracts other than count and not to exceed amounts, it's very likely that someone is trying to figure out the answer to a complicated word problem. Claims data is largely arithmetic. Any summary data requiring categorization is a complex word problem that someone must work through to find the relevant words and amounts before categorizing summing and reporting to APAC. And that's really what I mean by using non-data as data and wanting to recognize the art and sophistication that goes into some of these and into the work of fitting it into categories. Next slide. So this demonstrates part of the APAC definition for primary care. We have taxonomy, as I mentioned, which could be either clinic type or provider type, and we're adding our 28th code that qualifies as a primary care provider this year. That's difficult enough, but then when you move into the second condition that must be met, we have 95 procedure codes and 20 diagnosis codes under G and Z categories that may qualify as primary care. This is difficult enough at our claim level, which one of our analysts that produces our primary care report will gladly tell you. Taxonomy is probably giving him nightmares at night even now. But once you try to move it into a contract format, again, you really are looking to an art, a level of knowledge that may not exist, and we're in the realm of best practices. And I think that's why Michael was talking about when you have these large descriptions, you might want to rely on a percentage to associate with the primary care portion of the payment. Next slide. So Michael recommended a standard categorical framework, and Oregon back in 2016 selected, or 2017, selected the HCP land, so the Healthcare Payment Learning and Action Network. And even then, we have introduced two relatively clean variations. First, we allow people to report a fee-for-service payment that interacts with another contract that is non-fee-for-service payment methodology as a 1A rather than simply a 1. Most commonly, this is pharmacy costs associated with a shared risk or savings based on average total cost per member, but there are other occasions where you have these reported as well. The second is because this report serves several purposes. Oregon needs to split out what is the patient-centered primary care home payments or not. So we've got a 2A and a 2AI and a 2AII to say whether or not it's a primary care. That's relatively easy if you are directly contracting with a PCPCH. If you're going through another contractor that then has contracted with a PCPCH, this might be quite complicated for you to be able to tell us. Then we have issues like how much is meaningful risk for a shared savings or shared risk program. We do have a frequently asked question on that point, but we have not included it in our, I have included it on the slide certainly, but we also haven't included it in our file layout because again, we realize that we've assigned some numbers, but if people want to argue different options to us, we're open to hearing for those. I just really wanted people to understand how complicated the analysis is to change narrative and group payments into the nice columns that are being sent to us. So I also want to mention that correct reporting of the land category is essential to OHA because our coordinated care organizations are required to meet a threshold for spending, increase that each year, and move to the right of this list, away from 1 and towards 4. And we always favor categories linked to quality. So in some ways, a 3B is superior to a 4N because of the quality link. So this is very real to us. CCOs get payments or other considerations based on their performance on this. So I just wanted to really stress that this is not theoretical for Oregon. We are using it, and that both strengthens the importance of the information and what we hope to be the accuracy of the information. So next slide. So resource planning. Because I am myself on the ground floor, I want to include some considerations for the implementation and maintenance of a program. A strong program can fail if resources don't match needs. And that is true universally. So as you plan to incorporate non-claims reporting at other than the encounter level, which we capture in the claims files as encounters, it's important to consider how it interacts with other activities for the reporters, your staff, and your IT, whether internal or external. For example, when our payment arrangement file was pushed back because of resubmissions from prominent carriers, our next quarterly claim status processing was delayed by 2 weeks. So unless you're going to fund completely independent systems for this, there are interactions. Certainly there are interactions on timing and staff efforts for the reporters, the vendors, and internal staff. This isn't something I expect an advisory group to be active in, but I would recommend to an advisory group that you make sure someone is paying attention to this and seeing that it happens. Think with a good product.
Oh, Karen, we seem to have lost, oh, never mind.
Sorry about that. Next slide, please. Oh man. So an example of a multi-purpose tool is a good communication plan. Communication is such a broad term, including clear contract language of the vendor, clear laws, rules, and regulations with the reporters, and information for legislators and other stakeholders. And my dog has completely thrown me off. Okay, so my recommendation is the less frequent the interaction, the more important the communication is. Communication occurs naturally for APAC with each submission. Reminders are sent, results are shared, problems are discussed. But when the submission is annual, the same naturally occurring communication can seem untimely to the level of effort we were just discussing as needed for the payment arrangement file. The other part of communications that's very important to us, Michael recommended a technical advisory group as his 5th recommendation, and I could not agree more. Our tag is very important for our understanding of business activities and communication needs. And they are really an excellent advisor and sounding board for our own ideas. Next slide. So APAC gained a technical advisory group or tag a couple of years after the program was created. Since it's not in statute, as it is for many subsequently created programs, we can be flexible with the individuals attending our meetings to best meet our needs and theirs. Whether formal, and tag is in our rules but not our law, or informal, the practical knowledge and experience we gain from tag meetings is invaluable. In addition to the direct benefit, we have the indirect benefit of feeling comfortable, hopefully on their side as well as our side, to ask questions and make suggestions before a problem occurs, before the routine communication points of contact would be available to us. Next slide. So, and then with the best plans, communication is complicated and requires internal coordination as well as external exchange. And it's an example of communication on primary care. There are 7 definitions of primary care at OHA. So whenever we communicate with someone about primary care, we try to be careful to say, as defined by APAC, as required by the statute, such and such, this is our definition of primary care. The Office of Primary Care has a very different definition than we use. And as I said, there are 7, and the Value-Based Payment Compact is trying to develop different packages that would be primary care packages, which may or may not meet the current definition that APAC has based on statute for our primary care report. There are several groups, including the Voluntary Compact, that speak about primary care. So we want to make sure that we are not confusing anybody who is receiving the information by saying, you passed on this point, but you failed on this point, and they're both called primary care. And then the efficiency of using one report to serve 3 programs is wonderful as far as continuity of information and simplification of redundant steps for the data submitters. However, it doesn't actually decrease any work on part of APAC. With all of this visibility and use, we still average 4 to 8 resubmissions a year at somewhere along the process for our value-based payment, our payment arrangement files submissions. Next slide. So as I stated earlier, contracts are generally not written in land categories where data is already tabulated and simply being transferred. This means someone's using the communication previously discussed to determine the contracts to include, the amounts to attribute, and the categories to assign. So what happens after the data comes through the door? Because we've talked about what happens on their side. My recommendation is to apply data quality checks at each step. Claims data is generally arithmetic, and payment arrangement files are word problems. At the best of times, errors are going to occur. APAC has 57 validations applied to the payment arrangement file and 37 for the control file. And we'll talk in a minute more about those validation rules, but again, communication raises its hands. Our validation rules are available in our submission portal. We have a frequently asked questions document that we share online that try to answer some of the questions in advance that people may have. And our vendor has excellent response times on questions and provides details to clarify what is tripping up a file. So this is absolutely not independent of communication. So next slide. So this is an example of one of our fields and the 2 validation rules that apply to it. Because the interactions between our instructions and the validation rules is essential. And this is something we've been working on the last 2 or 3 years, where we realize we need to clarify something. We either need to have the validation rule modified to fit our expectation, or we need to clarify the description and valid values explanation in the file layout to make sure that we are getting what we expect. So in this, we've got a relatively lengthy description that says that member months at the contract payment methodology level, members are reported by stratification of the payment arrangement under the contract based on months in membership. So an individual could account for anything from 1 to 12 months in this annual file. They only report that if they are the primary payer. We only accept whole numbers, no decimals for this field. And you complete this field for only a few of the land categories, otherwise you leave it blank. Then at the bottom part of the slide, you see the 2 validation rules that are applied that again try to determine when it cannot be blank and when it should be. And then that when it is filled, that it is a full integer. So we really try to coordinate these 2 pieces to be able to provide, well, one, it's great data processing and helps decrease the cost and the rework and doing data processing at all levels. But 2, we really, again, want to give the best information we can to the reporters to honor the work they're having to put into giving us these files and not say, oops, we meant something else. Next slide. So in data validation is really where the 57 and 37 validation rules apply at the field level. We're checking populated when required, blank if not required, or required to be blank. And then the format is a lot of the validation rules. No dollar signs, explicit decimal limited to 2 places. Then we look at interactions within a row. For instance, the total paid cannot be less than what was paid under primary care or non-primary care. And then because this is summary data, we do look at, we use the control file for the whole file to make sure we received all the rows, everything that the reporter thought they were sending us is in fact in the file and we can match those up. But we also do historical comparisons now that we've got a few years in place to say if this was more, or if it's 20% lower than you've reported in previous years, we just want to check with you and make sure that's what you were expecting. Doesn't mean it's wrong, but it's like, wow, we need to ask about this sooner rather than later so the data can be processed and we can use it to build the reports that people are waiting for. And my final point is because this is summary data, we've not yet found a full replacement for eyes on review. Nothing can replace the human brain at this point for understanding the differences for it. I'm sorry, next slide. So Of course, we've got substantial information on primary care services in our claims file, whether it is paid as a fee for service or it's reported to us as an encounter. These are not intended or expected to be the same files because they have different selection criteria, among other things. Sorry, this is the most important one. But as part of the eyes on review, we do sometimes go and look at the claims file. Again, not to say one is right and one is wrong, but if we've got questions on the payment arrangement file, the claims file might help illuminate whether or not it really is a question, or we can understand what was happening based on those encounters that we can see, or to help us formulate a more specific question for the reporter that's going to be easier for them to respond to. So next slide. Okay, in my experience, almost all of compliance is about competing for resources, not about unwillingness. So just as communication touches all activities for better or for worse, compliance is a strong tool throughout the submission process and should not only be used in cases of failure. For important payers, timing of compliance efforts is critical to the availability of sufficient data for analysis. We currently have a 30-day cure period in our rules for compliance. This works fairly well for quarterly files, but doesn't work really well for annual files unless you just intend to wait and delay use of the data for the corrections to come in. Fundamentally, the value of compliance is to make it worth the organization's efforts to, whether it's to avoid a civil penalty or another mechanism, to get approval to do the work. Whatever, most of us have to ask someone for permission to do work task L instead of work task B. And compliance is the tool for resource allocation at the reporter level. Next slide. We also promote strong and timely data through publication. And I consider this to be an indirect compliance and data quality activity. Next slide. Certainly, there'd be no purpose in collecting the data if we didn't share it and we didn't use it. And the direct goal of sharing the data publicly is for use in information and policy decisions. Data that sees the light of day in any format, and sometimes sees the light of day at the level of the legislature or with a accompanying press release, strengthens the reporting and the completeness. This falls into the better late than never category as far as data quality, but some mandatory reporters discover errors at the point of publication. You should be prepared to decide whether you're going to publish with the error, you're going to give the reporter a pass by leaving them out of the report, or you're going to hold up the report until they can submit data. In any of those outcomes, you need to consider your publication needs as it relates to formal and informal compliance. Two uses that we have here at APAC, and next slide, please. Our healthcare payment arrangements file. I have two screen prints from it. This shows our coordinated care organizations information. And what I want to show is that we put out and publish the information in quite a bit of detail identified by the CCO. Next slide. Similarly, we serve as the prominent carriers report. So commercial carriers that have more than a certain threshold of costs and premiums billed also get reported at the identified level by the category they fall under. So recommendations, I'm not going to really spend much time on this, the who and the what. Under communication, I'm sorry, next slide. Under communication, I really strongly recommend having direct access to the mandatory reporter components at all relevant levels. Most of our work happens with the business lead and the IT lead, and that works fantastic. When you need access to the compliance officer, though, we have found it to be ineffective that at that point you have to reach out and ask who the compliance officer is. It's much better to already receive that information. Starting last year, we now have a standard form we collect once a year, and then as changes occur, where we collect the contact information for each of these 3 points. Next slide. Similarly, validation is valuable on any data set. And then final slide, again, just a reiteration that compliance should be used throughout the process, not just the end. This is not intended to be draconian. Just start the process with an understanding of whether the activity is voluntary or required and the timeline to perform whatever activity is. Don't contact a reporter partway through the timeline and then tell them that it is in fact required, because that's really, in my mind, that's disrespectful of their time and their competing activities. We want to give them the full range of activity time to be able to plan our needs in with all of the other things that they're trying to do. So I am very happy to say that the next slide, it just has relevant links. And now I'm gladly going to stop talking and see if there are any questions.
Hi, Karen, this is DC Dugdale from UW Medicine. From how many organizations do you receive data?
I'm sorry, was that the count or the
Yeah, approximately how many organizations send data to you?
for the payment arrangement file, approximately 50. We get them from the medical insurers and the dental insurers, third-party administrators.
Okay, great, thanks.
Questions? And I do just want to note the time. I know we want to make sure ask Karen what we need to, but we also got to get to voting on our code sets and the polling on this. So just want to note. We may get underway with the polling unless there are additional questions. And Karen, thank you so much. We really appreciate you coming today to speak. And also, just a side note, dog interruptions are common in my household too. I have a corgi and he is a lively one. So I believe you may have said it was a Chihuahua in your case, but.
Yes, this was really great, and I think has given us a lot to think about, which is all very good.
Great. So to folks, Shane, I can't see the code on the poll. It's obscured by the top. Is it the same as before?
Yeah, that's not actually me presenting, so let me.
Oh yeah, sorry.
And we're going to be relatively brief here. As I noted before, there's a body of work to see what current processes are to take this incredibly valuable, boots on the ground lessons learned from another state and to figure out where there are gaps in the process and where there's opportunity to improve on status quo. So we'll be coming back to discuss a lot of this information. So really briefly, I'll just open it up to see if there's key takeaways on this presentation, and then we'll move on to voting for the code set to wrap that up before going into public comment. So we'll give it just maybe a minute and a half here for some of the most important takeaways here.
Oh, Shane, are you displaying on your screen? I just don't see it.
If I click one more button, I will be. Sorry about that.
That's all right. Just want to make sure. There we go. And just a note, David, I see you and Sarah in the attendees. So my colleague may send you an invitation to join as a panelist. Please hit accept on that. Don't decline that invitation, and then you'll switch to a panelist. That way you can easily unmute yourself when we talk through voting on the code sets.
I think this is really, this comment's really hitting the nail on the head here. Essentially what we just saw is that the complex is genuinely quite complex, going from soup to nuts, from the actual definition of what you're trying to collect, the coordination with the submitting entities, the validation, the compliance, and then ultimately some policy around how that data is used. And there is a lot of work for us to figure out what those processes need to look like to get all of the use cases for these data fully addressed at the end of the day. So true. Big thumbs up on that one for me too. All right, I'm gonna keep us moving here so that we can wrap up the code. So thank you for flagging that, and there'll be more discussion on this to come. In fact, I might actually go ahead and skip this particular poll. I think that a lot of the things that you flagged earlier are at that high level for policy and strategy, which is probably where we're going to want to start. And then diving in on the detail is something that'll come in the future. So with that, I would just say thank you again, Karen. I think that the level of detail is just going to really inject some jet fuel in this process, and we couldn't have done that without you. So thank you very much.
Very grateful for the detailed template.
Yeah. All right. I know you've all been waiting with bated breath to get back to voting on codes. We have 4 left, 4 categories left. I'm just going to go ahead and dive in on this. It's the same process. So you'll see the code list. You'll see what the relative prevalence was from other states. There'll be some discussion if you want to make a recommendation around changing what's included or excluded for a code set, you can certainly do that. And then we'll go to a poll to finalize the vote. So we spent some time, oh, Judy, do you want to take it away? Or I don't want to step on your toes at all.
Oh, you're on
Okay.
okay, but you're good. That's okay.
I'm on mute. No, you're good. You keep going.
Okay.
I'm ready to make a motion.
Okay, great. I like it. Great. So we talked about obstetrics last time, and actually before that as well. We started a vote. We were right at the buzzer, so we didn't really get to complete the voting process. One thing I would say is that a few people did manage to get their vote in as the meeting was ending. We did get across that threshold to pass it as excluding everything as listed here. However, not everyone was present for that. So we're going to do it again. I would just note that that's where we landed, to the extent that that makes this vote a little easier this time. Before we go to voting on this, is there any discussion above and beyond what already happened last time and previously before we go to a vote on the recommendation, which as listed would be to exclude these codes from the primary care definition? Okay, hearing none.
I move we accept the recommendations for codes on this slide.
Second.
Okay, moved and seconded. Any discussion? Okay, seeing none, same process. So here it is agree, disagree, and abstain. It is locked, so let me unlock that. There we go. Jean Marie, what is our
Yes,
count of participants today?
I think we have 13 folks today.
Okay, great, thanks.
It's the majority.
Shane, this is David. I'm sorry to be late. I can't remember how to vote. Can you just tell me real quick how to do it?
Yeah, absolutely. There's a link in chat, and also at the top of the screen, you can see it's pollev.com/CEBP-OHSU 925. If you put that in, it should take you to a screen where you can input your vote.
Okay, thanks.
Yeah, absolutely.
If I can't figure it out, I agree.
Okay, I appreciate that. Thanks. I'll keep this moving. we do want to make sure we're capturing people's voice here, but we are certainly past the approval threshold. So we'll give it 10 more seconds if you want to lock in your vote. Otherwise, we will call that good and approved as moved. All right, there you have it. I'll lock that down and we will move on to the next category. So here, ontology services, you can see that we just have a fairly limited set. We have 4 codes. This is not typically included in definitions across I think we had 13 comparison points for other definitions. Similarly, the recommendation is to exclude these codes. Is there a motion or discussion?
I move we approve the recommendations on the slide.
Second.
Okay, moved and seconded. Any discussion on the motion? All right, well,
Let's vote.
Hearing none, let's vote. Yeah.
Thank you all for being so swift in your voting. That's great.
Got a lot of practice. we went through a lot of codes.
Maybe just give it another sec. Jane.
Yeah, have 10 more seconds if you want to chime in here.
Yeah, I think I counted 13, not including Judy, so 14.
There's our 12. Yeah.
Yeah,
Okay.
we're good.
All right. Well, we'll lock that down, and that passes as moved. Here, it gets a little messier. So this is the other category. There's a couple of things I want to point out, which this is not a unilateral recommendation to either exclude or include. Please take a moment to look at this first list and see which codes are recommended to include and which are included to exclude. For the most part, it's exclusion. The 4 that are recommended to include are related to removal of a contraceptive capsule, insert drug implant device, remove drug implant device, and I'm not exactly sure what that means, but remove with insert drug implant.
I think those are IUDs, right, Judy?
Yeah, they're all contraceptive,
contraception. Yeah.
family planning services. Yeah.
I think they're LARCs.
Yes.
That is
Things
correct.
that you stick in your arm or things that you put, yes, in the uterus.
This DC, I have a question about the 2 derm codes, 17110, 17111. These are actually pretty common primary care procedures, though I'm quite sure dermatologists do them too. Do you have a way of knowing in whatever claims data you have access to, how often those are done by those 2 respective fields?
I'm going to chime in here. So one thing that we are discussing internally with HCA is using some Medicaid data as a proxy, or potentially even broader APCD data, to do just the utilization extraction so that we can answer some questions like that. Our goal with that analysis, assuming that we're going to be able to do it, which we're still working on that, is that we could use it to answer questions just like that. So are there codes where the committee's preliminarily recommended to define it as primary care, but the utilization data suggests that it's a 99% specialty code? We'll have some of that information hopefully in the future if we are able to pull that analysis off, but we don't have that answer at this point for you. But it's a good call out. That's the exact type of thing that we do want to keep poking at.
So are you
Any
saying that
other-
if we vote on this, there'll be a chance to answer that question before these are finalized? Is that what you mean, Shane?
That's the general plan now, but I just have that caveat of we need to make sure that we have the resources to be able to
Sure.
do the analysis before we can 100% commit to them. But that's the intent.
Great, thank you.
Yeah, absolutely.
Yeah, we're hoping to have a plan that we go over this again, just to see, are there things that we've included that have a very low volume and aren't really worth putting in here, or are there things that are done by a very high volume by specialists and it's hard to tell the difference about where that happens. We've tried to put some things in place, but I think as particularly our last presenter shared in the non-claims based, it's not always that easy to tell. So yes.
Any other questions or discussion, or does anyone care to move the recommendation?
I move we adopt the recommendations on the slide for codes that are included and excluded.
I will second that, Madam Wiley.
Okay, great. Any additional discussion? All right, let's vote. We'll give it 10 more seconds here. We are past the approval threshold. All right, thank you very much. So that is
last one.
approved. Other part 2. So all of the previous comments apply. 1, it's a little messy. 2, there's a mix of include and exclude. So just make sure you take a moment to do that crosswalking to make sure that you agree with the recommendation before we move on.
This DC again, I have a similar comment about the lower 96110 and 96127. But those are definitely done in primary care. Maybe Cheryl can speak to the 96110, but these are really common primary care codes, I think.
Yeah, I completely agree, DC. I mean, we do those all day, every day in PEDS primary care for sure. I mean, that follows Bright Futures recommendation. It's actually required as part of the EPDST. So I would recommend including 96110 and 96127.
Proposed amendment, is that what I'm hearing?
Yes, if that's the
Yes.
correct term, indeed. Thank you.
Yes.
I'll second that proposal. I'm not sure if that's the proper thing, but I would.
Okay, any discussion?
Then Judy, do you want to rephrase the motion as the amended motion?
So I
Oh,
don't think
hey,
we have
may I
another
ask
way
a question
to-
before you do that, though?
Oh, sure.
I have another. The 99495. There's another one there's a transitional care management 7-day, right? And a 14-day.
Yes,
That's
there
correct.
is.
Yeah, but the transitional care management 7-day was on a different slide group, because when that came out, I
Yeah.
looked for the 14. It just
Oh,
happened.
what? Okay, thank you. Did they include it?
I think we included it.
Okay. Thank you.
And that's my question too, on the insert the intrauterine device. Do we somewhere have remove it? Like we do with all the
Yeah,
other?
on
It's
the
the flip.
on the last one slide that we just approved, it
Oh.
has removing.
Perfect.
Yeah.
Thanks.
Sorry, Judy, I think I overlapped on you. You wanted to say something. about-
Yeah, no, that's okay. I don't think we have another way to vote on this slide for the amendment. So maybe I'll say, I move to accept the recommendations on this slide, except to include 96110 and 96127 to be on the included list.
That works. Okay, any other discussion?
Oh, is there a second for
Second,
that?
yes, I would
Yeah.
like, does anyone second that? Cheryl?
Yeah, I will
Not to
second.
call you
Yep,
out.
absolutely.
Maddie, DC, all of you talking people. Any other discussion?
No, I think that's good.
All right,
Let's
so
vote. I think this is our last one, right?
It is.
Woohoo!
I sure hope so, because otherwise I mispromised. So all right, we're quite close to everyone. We'll give you 10 more seconds here to enter if you'd like to chime in. Okay, that passes as amended. Thanks very much. It was, in fact, the last. I really do want to commend you all. I know that was quite a slog, but that really tees us up for next steps really well. So well done.
Yes, it is super helpful. Thank you all. We got quite good at it. So hopefully we'll remember that skill later on. So now it's time for public comment. And Jean Marie, with this new format, I'm not 100% sure how to do that. So I'm passing it off to you.
No worries. So basically we have, it looks like we have 2 attendees, one identified by name. And so if you want to unmute, I believe you have to request, and then my colleague will unmute you so you can speak. So Katerina, I see you, and I'm not sure who the WISMA representative is, but did you want to say something? And Serena, do you have the ability to unmute them?
I don't see any hands raised.
Okay.
So yes, raise your hand if you want to talk, and but if there are no hand raised, you're also welcome to provide comments in writing via email at any time. And I'll pause again to see.
I know it's a new platform, but I do think the hand raising is still an option to indicate.
Yes, that you want to talk.
Okay, well, Serena, if you're not seeing anything, I think that is it. And look,
Yes.
3:45.
Wrap up. Yes.
Great. Judy, you want to take it away?
And let's do it. So thank you everyone for your participation in today's discussion and voting. I think, Jean Marie, are you going to review the committee's charges from the legislature?
At the next one? At the next meeting, you mean?
No, like anything else this meeting? I'm reading the script.
Oh, I didn't have that on my script, so.
Oh, okay. Well, we're not going to do that then.
Sorry. I thought,
That's okay.
We're hoping to strategize further on methods to measure non-claims-based payments. But
Yes.
I think you may be thinking of, we do have a joint meeting with 2 of the board's other committees coming up on the 6th, and we will be going through the various charges that have been set by the legislature to this group to review with them, to kind of look through all of the pieces that have come together on the claims-based portion on providers, facilities, and codes. So that's in.
We'll share that information, and then yes, now that we've sort of digested some information about non-claims based payments, at our next meeting, we're going to start to dive into that, figure out how we want to do it. Thank you all for attending today, and the recording and summary of this meeting will be posted shortly on our website. And we meet next June 28th at 2 p.m. and I look forward to seeing all of you there.